All of your respective organizations are on record in opposition to the legalization of assisted suicide. To give our attendees a sense of breadth of the disability community's opposition, I wanted to briefly highlight a few facts from the list of disability rights organizations that oppose assisted suicide that show the breadth, diversity, and extent of opposition to legalized suicide from within the disability rights community. One entity that stands out in the list is the National Council on Disability. Although it sounds like a disability organization, it's actually an independent federal agency that advises the President of the United States and the U.S. Congress. Notably, NCD has been vocally opposed to the legalization of assisted suicide since 1997. Even before the first state, Oregon, legalized the practice. NCD has weighed in against assisted suicide repeatedly over the years, and as recently as 2019, with a comprehensive report advising state policymakers to reject this dangerous practice. NCD is a bipartisan agency comprised of 9 council members appointed by the President and leadership in Congress. Notably, NCD has weighed in against assisted suicide during both Democratic and Republican administrations. Another one of the numerous national groups that oppose assisted suicide is the ARC of the United States, which is the largest national community-based organization advocating for and with people with intellectual and developmental disabilities, with over 600 state and local chapters across the country. Vincenzo, your organization, United Spinal, has a long record of opposition to assisted suicide and has access to over 100,000 wheelchair users, over 50 chapters, over 180 support groups, and over 100 rehabs and hospital partners. And finally, the National Council on Independent Living, or NCIL, is the longest running national cross-disability grassroots organization run by and for people with disabilities in the country. So this is far from a comprehensive list, and it's just a snapshot of the extent of the breadth and opposition. Clearly, disability groups have, contrary to the opposition's claims, coalesced around shared concerns with legalization for over 2 decades, and we're going to dive into why that is. So before we get started for our attendees' benefits, I think it might be interesting to hear about the origins of the disability resistance to legalize assisted suicide, which has been from the very beginning. Most people will remember Jack Kevorkian from the 90s. However, many people may not remember or be too young to remember the majority of his victims were people with disabilities who were not terminal. John, question to you, where was the disability community when all that was happening?
Well, Kevorkian became a sort of folk hero in the 1990s, and Not Dead Yet was founded in the context of him being acquitted a couple of times and a couple of Supreme Court cases. And the very first protest was outside Kevorkian's house. The Diane Coleman was a ADAPT organizer, and she founded our group and continues to serve as president and CEO. Not Dead Yet is the leading national disability rights group opposed to assisted suicide laws, euthanasia, futility judgments, so-called mercy killing, and any formulation of better dead than disabled. And yes, the New England Journal of Medicine later published a study about Kevorkian showing that 2/3 of his victims were not terminal, but very stressed out people, mostly women with disabilities. But unfortunately then, and continuing until now, the media and many people don't really differentiate between terminally ill people and non-terminal disabled people. So I would like to now share a clip by prominent bioethicist Thaddeus Pope, who in a debate with me in 2020 conceded that it really is all about disability. And in this clip, we are discussing a questioner who would like to be able to use assisted suicide to die because of feelings of lack of dignity over incontinence. So take it away, Matt.
To get out of the way, right? He's not asking for affirmative support or anything like that. He just says, just decriminalize it. Because as of now, the state government of Massachusetts has inserted itself between him, this questioner, and his physician. And then all he wants is for the state to get out of the way.
I would say that you've turned that on its head. The state gets involved by approving of the person's reasons for wanting to die and giving the doctor immunity by prescribing this. Now, if someone wanted to die because they felt that extraterrestrial beings were assaulting them and trying to kill them, well, they probably wouldn't be seen as rational. But as long as the formulation that it's rational for a person to feel lack of dignity over incontinence, then we are instituting massive prejudice against people who live with those conditions. That seems self-evident to me, and I don't understand how people can say, oh, it has nothing to do with disabled people, when it's all about disability. All the reasons are about disability.
Thaddeus?
Well, I mean, they are. I mean, I guess that's worth conceding, I think. They are all about it. I mean, his diagram, where he had the two Venn diagrams, right? Everybody who's terminally ill probably is definitionally disabled, right? So if you have metastatic terminal cancer, you're disabled. So everybody who's using medical aid and dying is disabled. And probably you could go to the next step and say, the reason they want medical aid and dying is because of their disability. It's because of the cancer or the side effects or the conditions from the cancer. So that's a true statement, but I guess the key thing is that's their judgment, right? Some people would say, I find this condition intolerable. People won't.
And the problem with this is that the state is sponsoring people's suicides because they are sharing hundreds of thousands of disabled people in the country. So we say we need equal protection under the law, and you know, just to make the point that this is most definitely not about pain.
That's
Ian.
Yes. Sorry, I was on mute there for a moment. Yeah, John. Briefly, how does the topic of assisted suicide implicate disability rights?
Assisted suicide violates the Americans with Disabilities Act, which promises equal protection under the law to people with disabilities. In the briefs drawn up by Not Dead Yet and Dread F, the Disability Rights Education and Defense Fund, we argue that by not providing suicide prevention services to suicidal disabled people, medicine and the state implement a policy of deadly ableism, better dead than disabled.
Yeah, absolutely. Thanks for contextualizing things at the outset here, John. If we can, let's pivot to legalization's impact for a moment. which has a lot of implications for people with disabilities. Shortly following California's legalization, the case of Stephanie Packer revealed an impact of legalization that did not surprise disability advocates, but was largely ignored in most media. Stephanie Packer was diagnosed with scleroderma, which ended up in her lungs, and doctors gave her a terminal diagnosis. She pursued a chemotherapy drug her doctors believed would extend her life, but her insurance company denied her coverage. She inquired instead if they would cover the prescription for assisted suicide, and they told her they would for a copay of $1.20. Lydia, what are the implications of legalization of assisted suicide in a profit-driven healthcare system?
This is Lydia. A profit-driven healthcare system exists within a context of societal ableism. John sums it up very clearly. We live in a society that teaches us over and over and over again that it would be better to be dead than to live in the world as a disabled person, that death is preferable to disabled life. And that message holds true whether people who are not presently disabled are thinking about physical disability, cognitive disability, psychosocial disability, or chronic illness. That message is so powerful and endemic that it affects the ways that we talk about disabled people's access to long-term supports and services. It affects the way that we talk about disabled people who are murdered by their family members and caregivers. And it affects the way that we've talked about disabled people during the last 3 years of this ongoing pandemic of COVID-19. Legalization of assisted suicide is another move toward institutionalizing the ableist belief that disabled life exists solely as a burden on our social resources and on our nation and on our communities. It harkens back to the very beliefs of eugenics, which many people do not realize was actually an export from the United States. A lot of folks associate eugenics era beliefs in Nazi Germany and with Adolf Hitler and the Third Reich. And the reality is that Hitler expressed open admiration for US legal policies and practices surrounding immigration, poverty, the criminal legal system, and disability. And those policies of state-sanctioned structural racism, classism, and ableism that led to and fueled the widespread use of different forms of incarceration, institutionalization, and state-sanctioned, legalized racial segregation are the very policies that inspired Hitler to devise his own set of eugenicist practices within the Third Reich that culminated in the Holocaust and genocide, targeting a wide number of communities, Jewish people, Roma people, disabled people, among others. So when we talk about legalization of assisted suicide now, it is impossible for us to have that conversation outside of connecting assisted suicide to care rationing policies, assisted suicide to policies that treat with leniency and fail to provide any consequences whatsoever to people who abuse, neglect, and kill disabled people. Legalization of assisted suicide is another way in which our current healthcare system does not exist to serve the needs of people who require access to acute or chronic care, but rather to uphold an agenda of lining the pockets of the biggest shareholders while legalizing institutional discrimination and prejudicial beliefs for the benefit and the comfort and the convenience of those who are privileged at the expense of those of us who bear the brunt of the impact of those systems.
Yeah, that's outstanding, Lydia. That's absolutely. It's also worth pointing out that national surveys of medical providers consistently show that physicians in the States believe that people with significant disabilities have worse quality of life than non-disabled people. In a December 2020 study published in Health Affairs, more than 82% of over 700 physicians stated they believed people with disabilities had lower quality of life than people without disabilities. And only 40% of physicians were very confident in their ability to provide the same quality of care to disabled patients as their non-disabled patients. I mean, I'm sure you could all provide anecdotes of your own organization's members' stories, doctors devaluing their lives, or examples of implicit bias and explicit bias coming through in healthcare provision. I certainly have a few from Canada, and certainly there was no shortage of those stories during the pandemic. So what we're talking about is a pursuit of a dangerous public policy on a collision course with an industry with a long-standing track record of devaluing disabled lives. So John, a follow-up question, please. If some people are somewhat surprised to learn of the disabilities community's opposition to legalizing assisted suicide, given the community's focus and priority on principles of autonomy, self-direction, and choice, how is the opposition not at odds with those principles?
Well, you know, to hear proponents talk about it, it sounds like a perfectly wonderful program in which you are sick and you are actually dying, and doctors can predict when you will die, and everyone is supportive of you. And it just sounds like a case of rational choice by an individual. But we learned quickly that true autonomy and choice are impossible without fully funded home care, as Lydia mentioned. So people would not be in the position of choosing between a nursing home that would drain their money and suicide. Right now, insurers are incentivized to cut costs by denying expensive coverage. For example, Dr. Brian Callister of Nevada discovered that 2 patients of his, who he referred for expensive but usually curative surgery, were denied by insurers in California and Oregon because the medical director said that they only covered hospice and assisted suicide. And then when family and caregivers send the message that you are a financial, emotional burden, and it would be better off for everyone if you died, autonomy is impossible. Safeguards cannot protect people from abuse behind closed doors. A self-interested heir, someone in line to inherit, can pressure someone to sign, serve as a witness, pick up the drugs, and even administer them without anyone knowing. And with doctors making so many mistakes, up to 1 in 5 people are discharged from hospice after outliving their 6-month prognosis. People will lose months, years, or even decades of life. No autonomy there.
Absolutely. It raises questions about choice when governments are making the choices for you. And please, at any point, Lydia, Vincenzo, jump right in, comments if they arise, if you have them, please. And before I forget, I just want to read a quote that I think is germane before I forget. And it comes from Derek Humphrey from Freedom to Die, People, Politics, and the Right to Die movement. So for those not in the know, Derek Humphrey is the founder of Compassion and Choice, is so renamed from the Hemlock Society. And as though a prophet of doom, he once said, "Economics, not the quest for broadened individual liberties or increased autonomy, will drive assisted suicide to the plateau of acceptable practice." And we're seeing that infiltration steadily cascade. It has certainly in Canada, where bean counting for the lives of Canadians has been reduced to cost savings. So that's a wonderful comment, John. And again, anybody jump in if you feel inclined to. And if not, we can continue with, there have been a steady stream of movies over the last few years that have depicted assisted death, suicide in a heroic light. Me Before You, $1 Million Baby, to name a couple. And although those are hardly the only examples of problematic portrayals of disability in context of suicide, and of course, the euphemism death with dignity, which has become so prevalent in these policies debates from proponents of legalization, suggests that there are certain disability circumstances which create an undignified status that is only escapable through ending one's life or having it ended for you in some instances. Oregon annual data shows that consistently that the top reasons people give their doctors for wanting to access the lethal medication are in relation to fear of losing independence, bodily functions, being a burden on others, not pain, as so many proponents suggest. And in fact, pain doesn't even break the top 5 reasons given. In 2021, 3 of the most frequently reported end-of-life concerns were loss of autonomy, decreasing ability, and excuse me, that's 93% with concerns with loss of autonomy, decreasing ability to participate in activities, that's 92%, and a perception of a loss of dignity, 68%, fear of being a burden on family and friends, 54%, and losing bodily functions, 47%. So Vincenzo, what is the danger of conflating dignity with the avoidance of things like losing your independence, bodily functions, a dignified life and the like?
Yeah, I mean, this is the whole conversation has so much to say, Ian, and let me share my own experience, right? So I am a wheelchair user. I have a spinal cord injury, and it happened. My injury happened as an adult, right? So from one day to the other, I lost my ability to control my bowel and my ability to control my bladder. Very dignifying, right? However, I was able to go to an amazing rehabilitation center that gave me all the resources to learn how to manage my bladder and how to manage my my bowel and all that. When this happened to me, life was over. I thought, oh my God, this is the end of my life. How can I live, like that? If I'm going to wet my pants, how would I work and all that? And I did consider, as many people with disabilities at some point consider, what's the worth of my life. But because I had the resources, to learn and to realize, I learned to live with a very high quality of life because I went to a good rehab center and all that. And I'm not only very happy with who I am, but I'm adding value to society, right? And I'm doing all that, being disabled and without controlling my many of my functions. So when you think about that, the issue is not the way, if I can or cannot control it. The issue is what society thinks the issue is, right? And therefore, we're not going to give you the resources that you need. I think that the anchor, it needs to be that that our rights are human rights, and our rights to live, it's unnegotiable, the same way as it's unnegotiable for anybody else. So, for example, if there is a person that is very depressed because he lost his job, he lost his car, he's lost his wife and all that, and he cannot live like that. Would you justify, him, help him kill himself? Probably not, right? You probably would say, no, you need to go to a psychologist, you need to go to a doctor and all that and work with that. But all of the sudden, for us, it's okay, because you're losing your dignity and all that. So it's not worth, making that. So the only difference between those two scenarios of high depression and wanting to take your life is disability. And that makes it a very dangerous violation of basic human rights. So it's a long conversation, and I think it has it goes to what's easy. One of the things that I always say, our disability are marked by lack of accessibility, right? If you give me, if you make this world accessible, I'm as able as anybody else. But it takes effort, it takes investment. And the reason why we don't invest on that is because we think that people with disability are not worth of it. And a law like, allowing assisted suicide, what it's doing is reinforcing the fact that our lives are less and are not worth living, which, retro feeds all those beliefs that are making it very complicated for us and therefore violating a basic right to live.
Yeah, absolutely. It's a primitive concept. I'm not so sure. It seems state-driven that the problem is created by the state, and the solution is prioritized over equal access to healthcare, to true egalitarian value for people with or without disabilities, and the access to curative, preventative, medicine and programs. And I wondered, with respect to that marginalization, Lydia, could you talk a little bit about the increased danger of assisted suicide for those from multiple marginalized communities?
This is Lydia. One aspect of the advocacy work undertaken by proponents of assisted suicide that deeply concerns and disturbs me is their reliance on drawing a parallel to movements for civil rights and bodily autonomy unconnected to disability. One of the largest organizations advocating for legalization of assisted suicide boasts having community advisory and leadership groups from various communities of color and from the LGBTQ community, and will often steal slogans or ideas from the movement for reproductive choice and freedom. By framing the issue of access to assisted suicide as one of increasing people's autonomy and choices, and range of choices of what to do with their bodies. And in so doing, they are positioning assisted suicide as an issue that marginalized communities should, of course, be in favor of supporting, but noticeably absent from this organization's groups of community members from various marginalized communities that they tout as supporting their work is the disability community, and particularly disabled people who also belong to communities of color or to the LGBTQ community. We are missing from this picture because, like other forms of systemic and structural discrimination, the ableist values endemic to and inherent in assisted suicide disproportionately impact people from other marginalized communities. Many people do not understand this, but should. Disability itself is more prevalent in every marginalized community than it is in every analogously privileged or resourced one, if only because of the impacts of environmental racism in disproportionately exposing Black and Brown people and other people of color to environmental toxins that can cause long-term and chronic disability from birth or throughout life, if only because of the impact of exploitative and extractive economic practices under a capitalist system that disproportionately contribute to acute and prolonged injury, illness, and disability, both physical and mental, in workers who are not provided safe and humane working conditions with dignity. If only because of the high rates and prevalence of interpersonal violence and abuse of all kinds, as well as state-sanctioned violence such as police brutality, that again disproportionately impact people in the LGBTQ community, in Black and Brown and Native communities, in immigrant communities of color, for communities of people who belong to certain marginalized religious groups, and for others who exist again at the margins even within the disability community. Those of us who already experience more than one form of marginalization are not only more likely to be or become disabled, but we experience ableism in further amplified ways. So if assisted suicide becomes legalized, the incentives for profit-driven insurers, for medical agencies, providers, clinics, and hospitals to offload troublesome or uncomfortable and disturbing people who they don't wish to treat or to support because they do not believe our lives have intrinsic value, because they do not see us as their peers, because they do not see us as community members, because they do not respect our dignity and quality of life, that danger only increases for those of us who are disabled and belong to other marginalized communities. And yet, those who advocate for expansion of assisted suicide love to use our communities as props to claim that assisted suicide is about promoting and expanding civil rights, when in fact it is the exact opposite.
Hear, hear.
I would just like to speak to this word dignity a little bit. And I think that calling these bills death with dignity is really the most accurate description, because the people promoting these bills and the people using these bills tend to be higher class white people who their whole lives have exercised a lot of control and look down on people with disabilities. When they themselves become disabled, they feel that their dignity has been taken away, and the only way to get it back is through death. Now, the meaning of the word dignity in this is the old-fashioned meaning, going back to Latin and French, where someone with dignity was higher class, was worthy, had merit, and other people had no dignity. Now, the UN Declaration of Universal Declaration of Human Rights redefined dignity as, quote, recognition of the inherent dignity of the equal and unalienable rights of all members of the human family. And that is the foundation of freedom, justice, and peace in the world. Therefore, no government should take a position that some people lack dignity that is only restorable through death. So any pretense that the state or the government is being neutral about this is just a complete falsehood.
Absolutely. And I think too that it speaks to this this insidious idea that the right to die was somehow birthed from certain quote unquote progressive governments. Everyone has the right to die. It seems as though the legislation is as a result of a pre-existing judgment amongst a political minority that arbitrarily deems that people with disabilities' lives are less valuable than those without, however temporary that condition may be. As you pointed out, John, it's worth repeating that assisted suicide is all about disability rights. So in light of the dangers we're discussing, John, proponents and policymakers who are pushing for legalization will often point to these safeguards. In Canada, the word is, protections has also been used, that these bills have the claim that keeps the eligibility to a small group of people and keep the practice safe. Could you explain why these purported safeguards, quote unquote protections, have little value?
Sure. Well, I'll go through them. For example, they stress that the individual must initiate the request and must take it themselves. But the reality is that we all live in a social context. We live with other people. Other people's opinions affect us. And when I feel like a burden, that means someone else is contributing to that feeling. They're giving me that message passive aggressively or with abuse directly. And when you feel like a burden, that means that someone thinks you are a burden. Then there's no witness required at the death, so there's no way to prevent a self-interested person from administering the drugs to the patient. Another safeguard, 2 doctors must agree that you are terminal. Big deal, it's 1 doctor and their colleague. 2 doctors can be just as wrong as 1, and we've seen cases where people live months, years, or decades longer. Then we have a waiting period, and that's supposedly so people won't do it on impulse or rushed. But the minute these waiting periods get instituted, the advocates come back a year later and say the waiting period is an unnecessary barrier to autonomy. So with this radical extreme belief in autonomy, any safeguard becomes a problem, a distraction. And so they're just there to lull people into thinking that this can be safe when it isn't.
Hey, and can I add one thing about what John was saying, that for our community, specifically people with spinal cord injury and disorders, the word terminal, it's a very it's a word that might give a lot of doctors an easy pass, and the hospital system an easy pass. If you think about a person with quadriplegia, that has a cervical injury, those folks, if they're not treated and they're not given all the support, all the help, they would die, right? Some of them would need respirators to live and all that. And so, however, what I can tell you, from my, and I'm trying to bring like my own experience here, I've got a lot of friends that, when they got injured, they were thought that, you're not going to live, prepare for the worst. But when there was the investment on treatment and giving them, making sure that they have access to all the things that you might need, they're still alive. And they're living, very fulfilling lives. And, and I can tell you, some of them are, brilliant people that, thank God that they are with us. So their injury, when they got injured, can be categorized as terminal by 1 doctor, by 2 doctors, or by a system that doesn't want to invest on them. So if we say, well, you know what, you're a quadriplegic, you're going to need help to breathe and to walk, and you need to be feed and all that, and if we don't, and that's terminal, and that's not dignified and all that, let's propose to you to kill you, and to take your life away, and when you're doing that, you're really stopping this person that might have the biggest potential, and if you give them the opportunity, they would have very fulfilling lives. So that terminally ill is something that really makes me very nervous, because it's, you know, it can be very relative, and it can be, you know, bent in so many ways that can end up hurting people with disabilities.
Yeah, well said, Vincenzo. And I think, you know, we're clear that, you know, these are nuanced positions by you know, many people with disabilities and the groups that represent them. And you know, we're talking about public policy here. It's and carrying on from mention of eroding safeguards in 2021 specifically. This is from Oregon State data that shows that people with illnesses who are not considered terminal, or let's say highly treatable, are listed among those who qualified and died under the law. So in 2021, specifically among those who were deemed eligible under these so-called tight eligibility requirements, these included people whose underlying illness was diabetes, anorexia, arthritis, hernia, which would have qualified me last year. In fact, a total of 8% of all people who accessed the lethal dose in 2021 were folks with these highly treatable diseases and conditions. So it's worth noting that, you know, many of these bills proposed across the country each year opt for words like incurable or irreversible in place of terminal. So clearly there's a want from the proponents of suicide to make it open to people outside those, you know, who are terminal in the traditional sense. And again, a perfect example is, you know, the verbal engineering that's happened in Canada, you know, post haste. Take psychiatric referral. In reality, any given year, again from Oregon, it shows that usually 1 to 3% of people are referred for a consult, despite the fact that clearly the reasons people have been giving for wanting the lethal prescription, we already talked about, speak to, at the very least, was situational depression. In 2021, Oregon data put the referral figure at 0.8%. So one person of 200 out of 238 who requested lethal medication was referred to for a psychological evaluation. We can speak to witnesses to the request. So in most of these bills based upon the Oregon law, the witness on the form need not know the patient, and one of the witnesses can be in error. Surely there's no financial incentive there. This safeguard's not meaningful given the high rates of elder abuse. The U.S. Department of Justice puts the figure at 10%, and other studies put it closer to 20% of all elders. So the potential for even, you know, the unspoken pressure alluded to by John, you know, from family, others, is there. Reasons people in the reasons people give to pursue the lethal dose, they cite burden to family as a top reason. Clearly, if the family is witnessing the request, there's no way to foreclose coercion. So a common statement made by proponents of legalization is that these laws are needed to give people more choices at the end of life. And Vincenzo, could you speak to that as well, please?
Yeah, no, it's the problem that I see there of the choices is that you're really not giving them the choices, right? All the choices that they can have. You're only giving our people the choices that are easy for you and for, you know, and financially cheaper, right? Which is that. But, you know, if they really were given options, you know, the option would be, you know, access to, you know, to healthcare, access to, you know, to qualified caregivers, access to information, and all that. So it's not about options, you know, it's not about choices. Precisely what it's doing that, it's limiting the choices and forcing you to make choices that are, you know, the easier. there, and the other thing that I was gonna share, Ian, it was related to what I think John and Lydia said, is that, again, what those laws are doing is putting band-aids into bigger problems, right? So, and I think John was mentioning it, if you have a caregiver that is not qualified, that is underpaid, and that, and doesn't know how to work with you, it's very likely that he's going to get frustrated serving you. And it's very likely that he might abuse you. And it's very likely that he will make you think that, you know what, you're just a burden, right? So why don't we think about making sure that, caregivers are paid, decently, that they're qualified? Why don't we make sure that we give options to people by making sure that you can get the services that you need to be able to live your life? The same services, it's and I hate to make this because I know it's very simplistic, but if you lived in a very rural area where there is the only way that you have to go from place A to place B is by car. If you don't give me the car, then I have no access to anything, right? So I might as well die. So what did we do? We build roads. We build cars that allow you to go from A to B. Why is that not possible for us? Why is that not that investment for us? You could have said, well, you know what, society, let's not progress. Let's kill everybody instead of, thinking about innovation. But, when you think about all those things, it goes back to undervaluing giving less value to people with disability, with saying, investing in a car on you, investing in a road on you is not worth it because you have a disability. And I don't know if it makes sense, the comparison that I'm making there, Ian, but yeah.
No, I think it absolutely does. I mean, it goes back to this notion of language that presupposes a pre-existing condition that's tailor-made for a certain group of people and not for others. By definition, we're looking at a bias here. So, similarly, John, proponents often claim that there's no record of abuse or disability coercion in the few states that have legalized, including Oregon. They say that disability rights objections are overblown and haven't materialized. Well, how would you respond to that?
Well, the public health departments are given neither the authority nor the resources to investigate anything. And then the witness to any abuse is dead, so they cannot bring the information forward. So, for example, it turned out a couple years ago that the Oregon Nursing Board heard about the case of Wendy Melcher, a trans woman who was terminally ill, but was not enrolled in the program. Now, her hospice nurse and another nurse, one of whom was having an affair with Wendy's partner, conspired to kill her by giving her massive doses of morphine through suppositories. Wendy died a couple of days later. The board dealt with it secretly, did not refer the nurses for prosecution. One got a suspended license for a year. Another was put on probation. Wendy's family never learned how she died until a reporter called a few years later. And a Oregon newspaper said that if nurses are able to go around the requirements, then everything is for naught. but unfortunately, the media is not interested in these stories. In another case, Tammy Sawyer, a crooked real estate broker, had a man with ALS move into her house. He died by assisted suicide, supposedly, and then she put up his house for sale against their agreement and deposited some of the sale money in her own account. Oregon never noticed. She only ended up in jail because federal investigators got her for the real estate transactions. So we're at a constant disadvantage where it's just assumed that everything is fine, nothing to see here, but meanwhile, people with disabilities are the ones suffering.
Yeah, absolutely. Yeah, thanks for those references, John. I mean, we don't have time to get into, all the other stories that example the clear abuses of the laws, but PRAF and Not Dead Yet both have stories on their websites that repeatedly refute the claim that there's no abuse of laws, and I'm sure in the very near future we're going to be noting the mirroring effect, the cascade from Canada into the States, and the horror stories of abuse of varying kinds that are increasing and have no basis, falling under any reputation, certainly in Canada, any reputation as being a conscientious, concerned healthcare for its citizen. So with that, I would, we're at 5 o'clock, and Lydia is away at the moment, but perhaps expanding upon my experience in Canada. I'm a lifelong Canadian, and I immigrated to the U.S. Under 6 years ago, and there have been some recent harrowing cases, as I mentioned, out of Canada, in which people with a variety of disabilities facing grim alternatives and institutional neglect have, in an absence of life-sustaining curative choices, demurred to assisted suicide, in absence of those critical supports and services. So anyone feel free to jump in, but Vincenzo, in the U.S., what is the availability and adequacy of long-term services and supports for people with disabilities? Would you say that the answer to the question is directly related to assisted suicide?
I think that there are not enough resources. That's the resources, and it's precisely one of the biggest challenges and anxieties that people with disability face day in and day out, right? So if there were the investments on on those resources, things would be completely, would be very different. And just a related topic to this, how that makes it very, very discriminatory of not only people with disability, but also the intersections like Lydia mentioned before. Because the people with privilege, they have access to a lot of those resources because they are, they are better off, right? They have the money and all that. But people that are of lower social economics, they cannot afford it. And because they cannot afford it, then therefore, for them, the option is the cheapest one, that is, assisted suicide. So what is happening there is that these kind of laws are discriminatory not only for people with disability, but to minorities, especially those of lower social economics, right? That make it very difficult to get to those resources, to make those resources accessible to them to begin with. But in general, the resources are very limited, and not only the resources, many of our public policies make it very complicated for people like us to get to those resources in a way that would allow us to live our life with the highest quality of life. And it's not on us, it's on those policies, it's on that lack of resources.
Yeah, well said, Vincenzo. John or Lydia, would you care to add to that?
Well, just looking at Canada, there's some horrifying examples of people denied basic support to live, but given euthanasia without a second thought. Sean Taggart was a quadriplegic with ALS, and he had a computer set up so that he could communicate, and he just needed a little bit more care each day in order to live independently with his family. But the community council denied him that care. His only other option would have been to go to live in a nursing home where he couldn't have his computer set up. So we said death is preferable, and he died by assisted suicide. And then we have, just as an egregious case, a woman nicknamed Sophia. She had multiple chemical sensitivities, and her housing was compromised by people smoking, by cleaners using harsh solvents, and she tried and tried, and for years she lived in her own bedroom trying to seal the world away. Eventually she went to assisted suicide. That is no choice. And I think at this point it might be a good time to play Thaddeus Pope again, talking about how he believes that what goes on in Canada now, which is euthanasia on demand for anyone with a significant disability, whether terminal or not. And if Matt, if you could run that.
About people's reactions to disability. Whatever patients found personally, quote, intolerable, end quote, Pope argued, such as incontinence in this exchange, warranted assisted suicide. Kelly quotes that language in his question here.
I think this question from John Kelly segues nicely into what you just mentioned. Mr. Kelly is parsing the distinction between disease and disability, I suppose. As he writes, hi Thaddeus, since the motivating rationale for MAID is finding the disabling features of your disease intolerable, based on a diminished quality of life, your logic suggests that MAID should be extended to non-terminal disabled people with the same disabling features that might make life intolerable. Do you foresee this expansion towards disability from disease?
So John is a very articulate and vehement opponent of MAID, and he and I respect his pushing me to clarify. I do think that there'll be an expansion. There have been bills that have taken out the 6-month prognosis or extended it, right? So we've had bills to go from 6 to 12 months, and we've had bills that would take out that altogether, right? And it would still require an incurable and irreversible illness, but it wouldn't have that temporal component that you'd have to prognosticate that death would follow in 6 months. So I do think we're going to see that, right? As I said, the big focus legislatively is on the types of clinicians. We're going to expand the types of clinicians from physicians to nurse practitioners and sometimes to PAs. And we're going to change the waiting periods. That's the big focus right now. But if you just look over the last, in 2020, 2019, 2020, you do see a fair number of bills tinkering with the illness requirement. It is worth noting when you step back and look at this from a worldwide perspective, the US is unique in being that demanding, right? So any other jurisdiction in the world that has made as a legal question doesn't have a strict 6-month prognosis like that. So the US is kind of unique in the world in being that limited.
Excellent.
This is Lydia. I apologize that I had to step out for just a moment. However, I have seen a number of questions come in the Q&A, and I'm not sure if they've been addressed, but the number of questions that I saw were from some folks who were talking about their own desire to be able to access assisted suicide, including at least one from a person who identified themselves as having a significant disability and being very educated and wanting to be able to make this decision for themselves. And another person mentioning that, you know, the three of us may not speak for literally every person. And I wanted to take a minute to respond to those comments because I believe that they raise a few very common misconceptions of our opposition to the legalization of assisted suicide. I belong to a number of communities in which it is commonplace for people to discuss openly both the experience of chronic suicidality and the experience of deciding to choose death for themselves at an earlier age or point in time than they otherwise might have died. And I have borne witness to other people in my communities choosing death. Usually this is the result of a person having experienced so much trauma, pain, or abuse in their life, often from systems, often from individuals, including from the medical system, that they have decided that the only logical or rational conclusion, the only way of taking care of themselves and their needs is to somehow find a way to no longer exist in the world. And this is a very touchy subject for a lot of people because on the one hand, there are a lot of people who talk about suicide prevention in a very moralizing way that vilifies and passes moral judgment on people for experiencing suicidality, for attempting suicide, or for completing suicide, without consideration for the underlying circumstances or context in which a person chooses to die by suicide. And on the other hand, there is a very pervasive belief, right, that we've talked about a lot today, that disabled people would be better off dead rather than disabled. That there's an assumption that for all people with disabilities, with all types of disabilities, for no reason other than the mere existence of disability, that life with that disability, no matter what it is automatically dispreferable to the experience of death. And of course we challenge that because that is an incredibly horrifically ableist belief and idea. But where I come from as an advocate who is very staunchly opposed to the legalization of assisted suicide and absolutely in favor of people being able to exercise autonomy over their lives is that, of course, if someone chooses to die by suicide, then they should be able to do so, and they already are. Someone who has already decided, I want to die by suicide, whether they thought about it for a day or they've thought about it for 5 years before coming to that conclusion, that they want to die by suicide, they will find a way to die by suicide. And I certainly do not believe in criminalizing people for attempting suicide but not completing it, or for being present in the room and being a moral support to their friend who has chosen to die by suicide. I know people who have been in that position. I absolutely do not believe that they should be facing some kind of criminal sanction or criminalization for wanting to be supportive emotionally and otherwise to their friends who've chosen to die by suicide. But legalizing assisted suicide is not the same thing as decriminalizing a person's attempted suicide or someone wishing to be supportive to their friend or family member that's chosen to either stop palliative care, to actively die by suicide, or to find another way to cease to be alive in this world. Legalizing assisted suicide is about legalizing medical professionals' ability to kill with impunity. It's not about autonomy, it's not about dignity, and it's not about choice. Autonomy, dignity, and choice always recognize that the full range of choices for a person include the choice to end one's life. As tragic as that is, and as much as I hope, and I hope most of us would hope, that we can provide people with the right support and change societal conditions so that the world is no longer unlivable for so many of us who are at the margins. And yet, that choice is still part of the full array of a person's ability to exercise autonomy. But that's precisely the problem, right? It is a person's choice for themselves. It should never be the medical system's choice.
And I would just like to point out that the alternative to assisted suicide is not unrelieved and unrelievable suffering. Palliative care has come a long way, and it actually empowers you and gives you control over how much pain medicine you will take versus how conscious you want to be. For example, I visited a disabled friend who was dying of colon cancer, and in order to meet with me and be as aware as possible, she shorted herself some morphine. So during that time with me, it was worth it to her to be more in more pain so that we could interact. Then she increased the drugs after I left. And as good palliative care doctors will say, you are in charge of how much pain you can handle and how conscious you want to be. And for people whose pain is not otherwise relievable, there's the option of palliative sedation, in which doctors will sedate you so the dying process takes place without any pain. So we already have a way to address this issue without endangering a whole class of people with a reckless policy.
Absolutely. Well said, John. It's 5:16, and we're nearing the end of our time. So you've already started, really, but if we could begin with a couple of lightning round closing questions, maybe a minute or so in response. So what would, starting with Vincenzo, what would your elevator speech or your quick explanation for why the legalization of assisted suicide is at odds with a disability rights perspective?
Yeah, well, I think we've said that a lot, but I think because it really, it really conflicts with all the efforts that the disability community has done in the last 30, 40 years for equal rights and to respect of our lives and to, and the value of our lives. So this kind of law really undermines and undervalues the importance of our lives, which is very, very ableist and has a very negative side effect to everything that we have done and we have accomplished in the last, 35, 40 years of the disability movement.
Indeed. John?
My elevator speech is, assisted suicide laws aren't about pain. They are about distress over becoming disabled and dependent on others. Supporters and users of the program are higher class white people, while poorer and people of color oppose by large margins. Innocent people die because of insurer denials, suggestion, persuasion, and abuse, by family and caregivers, and wrong prognoses. No safeguards are possible that could protect people from this deadly ableism.
Well said, John. And Lydia, could you close us out before we open to other Q&A, please?
Legalizing assisted suicide is not about choice, autonomy, or dignity. It's about codifying medical ableism, and it will have deadly, devastating consequences because it already has everywhere it's ever been legalized.
Absolutely. And to one of the questions, perhaps aggregated for brevity here, I would, with respect to the belief in autonomy and the ability to make choices, I would say I don't think anybody is opposed to autonomy and a freedom of choice, but it should be predicated on a transparency of language that doesn't later contradict its stated intention, which in many cases is the ever evolving problem with assisted suicide legislative language. It's inherently deceptive, and with that, I'd like to thank everybody for your wonderful responses today, for your participation. Great thanks to our expert speakers. We have 11 minutes or so, 10 minutes or so for a few questions. I suppose for those who, just to preface, for those who want to learn more and remember the talking points today and take them into their advocacy, what tools would be available to highlight. We're going to have, this has been recorded, and we'll make this available to later. So with that said, there's actually an interesting question from Ontario. She prefaces it's not really related to disability focus, but I think it is. Would anybody be able to speak to the influx of death with dignity supporters as professionals within the palliative care organizations?
It's terrifying because people with disabilities, we are already suspicious of medical personnel, and we're used to being, insulted, treated badly. And, I've been spoken of in the third person. You can put the wheelchair over there. People just assume that I don't live independently. And it's just, they have prejudice, and they use cases where people do not get the pain relief they need to make this into a universal case, when it poses terrible dangers to disabled people, people of color, poorer people, people marginalized by gender identity, and anything else that can be the subject of discrimination.
Absolutely. All right, we're at 5:22. I think we've answered a number of the questions already.
One thing I could speak to, Ian, is some people think that universal psychological evaluations will solve the problem of making sure that people are in their right mind. But these evaluations are not to see if people are depressed and can be treated for depression. They're simple capacity interviews. And as long as the person espouses the typical reasons for wanting to die, that social worker is going to approve it. So if the person says, everyone will be better off with me dead, my life is meaningless, I'm a burden, I can't stand the life I live, they get treated as rational expressions of autonomy rather than classic symptoms of suicidality.
Oh, that's very poignant. Absolutely. Does anybody else have any questions? We're at 5:23. Okay. Well, I want to thank everybody for all the attendees, and to the panelists especially for I think what's turned out to be a very robust conversation. And on behalf of PRAF, we're going to be doing more disability rights focused webinars in the future. So please, by all means, any subsequent questions you may have, you can send them to me, to Ian at patientsrightsaction.org. With that, any questions that were in chat that we that may not have been germane, we will address individually. And again, I want to thank our presenters, our panelists, in what's certainly a very ever-growing important issue. And with that, I hope everybody has a wonderful weekend, and look forward to seeing you soon.